morning, everybody. Great pleasure to be here. I want to thank Dr. Muthuswamy for putting on another great course. It's wonderful seeing a lot of familiar faces and friends, and make some new friends as well. Coming up to the podium, Dr. Kenneth Buck asked me, will this be exciting? Because, because hepatitis C has changed a lot. But I get my timer out. In the past couple of decades. So in the next 20 minutes, how much time do you have, Muhammad? 20 minutes? Okay. The next 20 minutes, we're going to cover three important objectives. Our aims are to review the manifestation of hepatitis C. We're going to then change gears to talk about treatment options and very briefly touch upon options we have today and in the near future for patients who failed or didn't respond to current antiviral therapy. And you've seen this slide 1,000 times about managing hepatitis C. We got first confirm the infection, look for comorbidities, make sure they're on dialysis and have cholesterol problems. Look at their genotype, confirm the infection by a viral load, assess your disease severity. I can't emphasize that enough. Define the disease severity. Are they cirrhotic or not? Because if they're cirrhotic, you're married to them. If they're cirrhotic, you're married to them because even if you cure hepatitis C, there's still a big risk of liver cancer. And assess compliance. This one's going to see you on a regular basis, or they're going to take your prescription and leave. Stop their medication and then get resistance. So it goes without saying that hepatitis C is a major public health concern. For the past 20 years, I use my words carefully, for the past 2 decades, hepatitis C has been the most common cause of cirrhosis, the most common indication for liver transplantation, and the most common risk factor for liver cancer. And in fact, if you see across the country, hepatitis C accounts for 30–40% of all liver transplantation. But what's emerging right now is that the wait list is changing in the United States. And as of November 2016, hepatitis C was overtaken by a big gorilla, by fatty liver. And we're going to talk about why that happened. Hepatitis C causes hepatic problems. It also causes extrahepatic problems as well. So when we see someone in the clinic, we quickly think, do they have kidney problems? Do they have any skin manifestations, the fatigue, insulin resistance? Is there a history of lymphoma? Hepatitis C is a systemic disease. Move away from the idea that hepatitis C only causes liver problems, but also emphasize the extrahepatic manifestations. This is from an article published now a couple of years ago about a lymph node positive for lymphoma. Treated, a patient with hepatitis C, treated with antiviral therapy, and the lymph node, I don't know if you can see that, went away. And Muhammad's thinking, oh, that's one case report, right? Similar problem we had at UCLA, a patient who had a cervical lymph node, positive lymphoma, genotype 4, mild disease, and unfortunately had Medicaid. And it took a month of arguing with the authorities that the indication for therapy was not the liver disease. It was a lymphoma. Indeed, when she got cured, the lymphoma went away. So the other thing to remember is that extrahepatic manifestations do not correlate with disease severity. So you don't have to have cirrhosis to get lymphoma, or bridget fibrosis to get cryoglobulinemia, or vasculitis. The degree of liver damage is independent of the risk for extrahepatic manifestations. Now, I got an email this past week about an editorial someone wrote from in Los Angeles about how hepatitis C, is a big joke. That how rare it is. It's not as common as we thought it was. And if you have it, you can't get drugs. And nothing be further from the truth. The biggest barrier to curing hepatitis C is knowing who's infected. With all this competition, we'll talk about the drugs very shortly, access has improved significantly. So for us right now, it's uncommon for someone to be declined for therapy. There's barriers to screening. People don't realize that using drugs in the 1970s was a bad thing today. They don't know that back then, they could have got hepatitis C from sharing a needle. Or they may not know what the risk factors are. We had a patient, a lawyer from Beverly Hills, say, I never used drugs. Never used drugs. You use cocaine, right? Yeah, that's different, isn't it? With acute hepatitis C. Or patients may think, I cannot be infected. I feel fine. I have no symptoms. The expectation of symptoms may also be a barrier. People think they have no symptoms, they cannot have hepatitis C. And thirdly, the stigma. Right, Gina? Would you tell your doctor to use drugs back in the 80s? No. That was 30 years ago. No one needs to know about this. Let them find it in the blood test. And lastly, the private care doctors, providers, may not also know the risk factors or have time to deal with these issues. Now, this is an old slide dating that, 20 years. 20 years. And basically, these are the original CDC recommendations for hepatitis C screening, right? If you ever used drugs, had a blood transfusion, if your mom had hepatitis C, if you have HIV, screen for hepatitis C. And then about 5 years ago, new recommendations came out that, hepatitis C is very common among baby boomers. 70% of all hepatitis C, 70% is found among baby boomers. So the cost-effective studies highlighting that screening baby boomers is cost-effective. Okay, that's great, right? Big problem. We have a whole new generation of people in the United States that love drugs. And if you go to some parts, and there's a study looking at urban versus rural areas, and I think this was in Montana or something like that, in the Midwest, published by the CDC, Distinguished Journal, highlighting that the hepatitis C rates are going high among young people, particularly people in the rural areas who use drugs. So we have problems with the CDC recommendation, screening baby boomers only. And I think if you have risk factors, screen everybody. It's a nice study also published by the CDC. And what the CDC was alarmed is that in the state of Kentucky, all these kids were turning positive hepatitis C. What the hell? So they started looking at the hospital, doctors are infected, nurses, what's going on? It turns out that this increase in kids being infected with hepatitis C paralleled the moms being infected. And what happened, you have a generation of young women sharing needles and getting hepatitis C, and all those are very uncommon given to their infant baby at the time of birth. So we see someone with hepatitis C, which is for comorbidities, CBC, metabolic panel, hepatitis B and HIV, look for other things. They have kidney problems or on dialysis or severe heart problem. Hepatitis B is a new warning by the FDA. And what's happened is in Japan, there have been a number of cases of people who were treated for hepatitis C. After they're cured, having hepatitis B reactivation, like that was described with chemotherapy. Now, my partner, Stephen Hahn, we'll be talking about hepatitis B shortly, wrote a paper about 20 years ago. And what he described is that when you have two viruses, two hepatic tropic viruses, hepatitis B, hepatitis C, only one virus is active. Generally, hepatitis C is active. Hepatitis B is quiet and dormant. So as you cure the hepatitis C, the virus goes down. Somehow there's less suppression and hepatitis B could reactivate. And there have been a number of cases now in Japan and other parts of the East where there's been reactivation and caused some bad outcomes. So right now it's recommended that if someone has hepatitis C before starting therapy, check for hepatitis B. And hepatitis, if they have it, follow the algorithms. If they're positive DNA, consider antiviral therapy while also treating for hepatitis C. The recommendations are somewhat vague. So I mentioned earlier that one of the tenets of treating hepatitis C is staging liver disease. And you've all seen the bottom cartoons at nausea for years about the severe liver disease from 0 to 4, 0 being normal, 4 meaning cirrhosis, and up there is kind of a bigger cartoon of what the liver looks like. So we have to assess for liver damage, and there are different modalities. Liver biopsies that no one wants anymore. I wouldn't want one either. Invasive, takes time off work. We have serum biomarkers. We have elastography, routine imaging, and the examination. Don't forget that. So it's important because if someone has cirrhosis, it may impact what therapy used for hepatitis C. And for some regimens, it may impact the duration or the need for ribavirin. And when you cure someone, they need to be assessed for decompensation and screened for liver cancer on a regular basis. So screening for cirrhosis is essential. We saw a patient from Bakersfield about a year and a half ago, a patient who had hepatitis C, cirrhosis, got cured. Woo, got cured. And then 6 months later, goes to the ER. Oh, it hurts. My liver hurts. Did a scan, had a huge liver tumor. AFP was 1,000. That was December. We saw him in January. AFP was 2,000. April, the patient died. And the family is saying, wait a minute, my dad had cirrhosis. Why wasn't he being screened for liver cancer? So we see this a lot. And even our own institution at UCLA, we're seeing this. So this is a very nice slide by the CDC. And it confirms an author named Gary Davis's prediction, published about 10 years ago, that today we're seeing around 17-20% of patients with advanced disease. This is based on looking at LabCorp and Quest, new diagnosed hepatitis C patients, calculating their fibrosis scores. So indeed, about 15 to 20% of people with hepatitis C do have advanced disease. Here are some laboratory assessments we do at UCLA. We calculate an APRI score or FIB-4. Basically, you get your little handy calculator. One of the fellows, where's Kevin Nguyen? Are you paying attention, Kevin? You look like you're falling asleep. All right. So Kevin actually showed me on Wednesday an application on your phone. You plug in numbers, right? And you get the APRI or FIB-4, and it predicts the amount of liver damage. You could also order a proprietary test called FiberTest or FiberSpec, and also gives you similar information. So we use that quite a lot as well to predict cirrhosis. Routine imaging, if you see a nodular liver or a dilated portal vein or big spleen or on ultrasound, the patient has cirrhosis or a CAT scan. The other tools, FibroScan, they're several in the city. Peter Owen has one. There's Cedars has one. A couple in Pasadena. FibroScan is another modality to look for liver damage. We've been utilizing more and more MR elastography. We love this procedure because it gives you a bigger view of the liver than the FibroScan. And when it comes to a fatty liver, that Ross is going to talk about very shortly, I think many people argue it's probably the best diagnostic tool for fatty liver to find out who's got NASH damage. And this is easy, decompensated liver disease, right? Yellow eyes, varicose bleed, etc. So antiviral therapy. We have a number of options, right? And we treat hepatitis C, we use a combination of drugs. If you use one direct-acting agent by itself, it may work, but if it doesn't work, you're going to get resistance. So we always a combination of drugs. And we use drugs from different classes that have non-overlapping mechanisms of action. A number of studies, and I just threw in this one as an example, but a number of studies showing that with curing hepatitis C, people live longer and better and decrease the risk of liver cancer. The data is all there. Most of the data, to be fair balanced, revolves on people who had advanced disease. If you ask me, how about people who've got stage 1, stage 2, where's the data for that? We just don't have it. It can be modeled in mathematical equations, but we don't have any real-life data because the data takes years to go forward. So treating hepatitis C is so easy. There are pills that are effective, safe, and tolerable. The question always comes up when we're talking to our colleagues is, what is the point of no return? When should we not treat hepatitis C? Is it a high MELD score? Is it a high Child-Pugh score? If someone's got liver cancer, or someone's got kidney failure, they're on the kidney transplant list. There's pros and cons. The benefits is, if you catch someone early enough, you can improve survival. We may take them off the liver transplant list. There's hard data for that. In fact, that's part of the reason why the NASH right now is becoming the most common reason for transplant. We've seen a decrease in hepatitis need for transplantation. It's been so gratifying. There's data about decreasing portal hypertension, and if you treat someone before transplantation, it won't come back and infect the new liver. But there's risk involved. You can't get hepatitis C positive grafts, so it may theoretically delay your transplantation. Risk of resistance if you don't get cured. And we're going to see sure the more liver damage you have, your cure rate does drop. We have an issue now at UCLA where someone got treated for transplantation, got transplanted, and we can't get this patient approved for a second course of therapy because nothing is FDA approved after you fail current therapy. So we've been arguing with insurance companies for 2 weeks, multiple phone calls. And I'm sure we'll get it, but it's been taking an act of God. We're going to talk later about adverse events and also retreatment option when someone fails. So this is from an editorial. It's going to be published in Hepatology this next couple of months. Kind of just showing all the literature on decompensated liver disease patient. And basically, you see here that the duration between 12 and 24 weeks. The MEL scores are kind of all over the place, but generally the MEL scores tend to be below 20 in these studies. But the SVR, the cure rate, does drop down with more advanced disease. And as your cure rate drops down, you also see more side effects. Now, what does that mean, these people who are already sick as it is? So we're not sure what that means, but there are pros and cons. And I think if we would treat someone with their child class A, maybe an early B, we might consider therapy. If they're a high B or child class C, there's not much benefit treating, and we'd rather treat them after liver transplantation, knowing the cure rate in a liver transplant recipient is as good as anybody else. This is a study published last year by Dr. Graham Foster, showing that with curing hepatitis C, again, the cure rates are pretty high with every regimen used. And there's also hard data showing that you can improve. In someone early enough, you can improve their MEL scores. Again, there is a point of no return. We're not sure what that is. Probably a MEL score in the mid-20s or high child B classification. This is a nice study published from Europe last year, and it was the first of its kind showing that after curing hepatitis C in select patients below MEL to 20, people could come off the liver transplant list. And I was never a big believer in this until I saw a guy last week who's 70 years old, who historically had ascites, encephalopathy, denied for transplantation. Okay, we'll treat him then. And we saw him last week after he's cured, and I didn't recognize him. Doing much better. The whole goal of hepatitis C therapy is to eliminate this, make hepatitis C a rare disease. And it can happen in our lifetime. There's a lot of initiatives by the VA hospital and other settings where hepatitis C could be eliminated. We're excited because we think in the post-transplant setting, after transplantation, we think we can eliminate hepatitis C completely. You see here that as we've had advantages of antiviral therapy over time, the proportion of patients we follow in clinical hepatitis C keeps on decreasing. I'm pretty sure it'd be down to almost zero. I was talking to Muhammad last week about how many people are waiting for a second transplant for hepatitis C, and that's actually pretty uncommon today, very uncommon. These are the antiviral therapies regimens available, and you see here that there's some approved for people on dialysis, some are approved people who are decompensated liver disease, and so we have a significant now options for patients. For genotype 2, 3, 4, 5, and 6, we also have lots of options for patients as well. This is from a nice paper published this year, just highlighting that caring for patients does not stop when you cure hepatitis C, particularly if they have advanced disease. Stage 3, stage 4, they need to keep on being screened on a regular basis. And equally important, particularly our younger patients, they have to be careful about high-risk behavior. Curing hepatitis C is pretty easy, but there's also a risk of reinfection. And in fact, and this is a very nice study by Eric Lawitz from San Antonio, very large population, and he looked at long-term cure, right? After many, many, many years, after you cure DAs, what happens to patients? Well, 99.7% of the virus still zero. And the most common reason for a virus to become positive again is reinfection. So the continuum of care doesn't stop with cure. It continues liver cancer screening, harm reduction, make sure they're not going to be reinfected, talk about their weight and alcohol, etc. Options for people who failed therapy. This has been a very difficult area of study, namely because therapies are so effective today. It's uncommon to have someone fail therapy with direct-acting agents. I mean, you figure the cure rate is like 95, 97%. So most of these studies on the left-hand side are single-center studies. 5 patients, 10 patients, 20 patients. And they all pretty much show a high rate of efficacy. So we've been using first the second row, particularly people after liver transplant and failed therapy. And I got to tell you, as in the literature, our cure rate's been close to 100%. We are anticipating 2 other regimens be approved later this year, around August and September. And these would be probably spearheaded toward mostly people who fail current therapies. So if people have failed therapy today, we have options right now. If they have mild disease, we'll tell them, why don't you wait till July or August? We have something FDA approved. If they're very sick on the transplant, they had a transplant, they're worried about recurrent hepatitis C, eating up the new liver, we'll bite the bullet and put them on therapy right now, knowing that's off-label. This is a nice study that Dr. Nguyen published this year, and showing that a number of our tools may become more accurate. He showed that AFP reduces after cure hepatitis C. And this is very important because, AFP has been argued to be a potential marker for liver cancer screening. But the problem with AFP and MPH hepatitis B or C, if there's virus involved, the AFP levels fluctuate. And what he found is that this AFP become more durable, more stable after someone's cured hepatitis C. So it may become a better marker in patients in the future. This needs to be looked at prospectively. How am I doing, Mohammed? Am I good with time? 2 minutes. All right. I got 10 more slides. No, I'm just kidding. So last slide. So remember, hepatitis C is a systemic disease. It causes both hepatic and extrahepatic manifestations. The old goal of therapy is to have someone live as long as possible. Most people with hepatitis C don't know they're infected. No one wears a badge. So if I got hepatitis C, screen me. We talked about those barriers to screening that people unaware of their risk factor, expectations of symptoms, or the provider not knowing what the risk factors are. And the majority of people with hepatitis C can be cured. In fact, the challenge for us is not who we could treat. Who don't you treat? Drugs that are effective, safe, and tolerable. We saw a lady not too long ago, true story. She's like 82 years old, and with hepatitis C. She looks wonderful, by the way. She's like she's 50 or 60. And she saw her doctor, and the doctor says, no, you're too old for therapy. Mama, what does she do? She starts crying. And then we see her, you're fine. Let's get started. And lastly, remember the hepatitis C treatment is a continuum. And it doesn't stop after someone's cured. People have to be educated about risk behavior, screening for liver cancer, and don't forget the other things cause liver problems, like fatty liver and alcohol. Many times you forget that. So at this point, I'm going to thank you again for the kind invitation, and I guess Dr. Alcabana should be the next speaker up.